Angelo Leto Barone, welcome to the podcast.
Thank you so much for having me. I appreciate it.
Angelo, you're in Florida, so it's good morning to you. And I would like to start from the beginning. If you could kindly introduce yourself to us and just tell us a bit about your background and how you got into the field of Microtia.
Absolutely. So I am a craniofacial and pediatric plastic surgeon practicing at Nemours Children's Hospital in Orlando. I have a passion for Microtia that developed when I was a resident, actually still in training, due to a very specific case that showed to me how technically challenged this operation is. And I was seeing when I was training that a lot of patients with Microtia were coming with suboptimal results. And I was wondering, how could it be that in this day and age, excellent surgeons even cannot have consistently amazing results? And I thought, we need to do better, and we need to do things a little differently and maybe modernize Microtia reconstruction a little bit. And I got inspired by a lot of the pioneers in Microtia, and I tried to revolutionize a little bit the field. And funny enough, I was talking to one of my mentors in residency, and I was saying, hey, what do you think if we created like a cookie cutter that allowed us to cut the subunit of cartilage, then we could wire together? Do you think that would help? And he was light struck, and he was saying, or lightning struck, and he was saying, absolutely, I think it would be great because it could make one of the many difficult parts of this operation much easier. So I invented a medical device that allows us to actually improve the quality of the construct, and we ended up patenting it, and then started to use it clinically, and we published it. And it's great because it allows us to do that in a more standardized fashion. And a lot of the Microtia repair is really the soft tissue envelope that is on top of it, not just only the formation of the construct. But I wanted to personalize it a little bit and make it easier for me, I guess. So this is really how I got into the field of Microtia.
So talk to us a bit about that, because I just out of curiosity. So I know the standardized way of doing the reconstructive surgery is using the rib cartilage, making the shape of the ear, and then taking a skin graft and putting it behind the ear. So what are you doing differently to say that standardized method?
Yeah, so when you have this device, which is a cookie cutter, instead of having to carve like a sculptor the cartilage from the ribs that you take from the patient, for example, you basically pass it through one of these two devices, actually, and you slice the cartilage so that you're not actually carving it and destroying the cartilage. You're actually just slicing it and duplicating the amount of cartilage you need. So we actually need less cartilage to do our operation. But also, instead of having to cut it by hand, because as good as you could be, a hand cutting is not as precise as machine cutting. So the machine then is like almost like a cookie cutter, and it cuts and it stamps out the pieces of cartilage that then you wire together. So it makes everything faster. I think, at least in my hands, the quality of the construct has drastically improved since I started using that. And then once we put in the subcutaneous pocket, we just use the regular Nagata technique.
Yeah.
And then I do something a little different that I've learned from some of my mentors. 6 months later, we make a cut right around here. We lift off the ear, and then I do a mastoid flap. So I take, instead of taking the TPF, which I want to save as a lifeboat later on, if there is anything that happens,
Yeah.
I just take a little bit of tissue from here, I flip it on top of a wedge of cartilage on a cartilage block, and then we put the skin grafts there. And I think it's a easier and I think safer way to do it because, again, you spare that TPF if there is a problem later on.
Do you mind telling us what a TPF is?
Yes, I'm sorry. It's temporal parietal fascia flap. So
Okay, what
it's
does that mean?
Yeah, so it's basically the tissue, the little layer of tissue that is on top of one of our mastication muscles, of the chewing muscles. It's called
Yeah.
the temporalis muscle right here that allows you to do that.
Okay.
And it's a great source of tissue, which is usually what, for example, the people who do the Medpor technique use to cover the Medpor implant.
Okay, that's super interesting. How long have you been doing this type of surgery for versus the standardized rib cartilage surgery?
Because I've invented it while I was a resident, even through residency, we were able to put a clinical trial, and I did a few in residency. And so it's been a while now. We finally got it approved in my hospital, so we're gonna start recruiting soon patients to get it done with this technique. But right now, I'm just hand carving it just because we want to make sure that things are done safely. So we have to go through years of regulations and approvals and before we could start the clinical trial. So the clinical trial is about to start. But I've been working on this technique for a decade, basically.
Oh, wow. It's keeping you nice and busy.
Yes. Yes.
So are you performing Microtia surgeries currently using the original method? Let's call it the original method.
Yes, I am. So I actually, when I took my job here in Orlando, one of the things that I pitched was the establishment of a center for ear reconstruction that I called actually Nice Ear, the Nemours
Oh,
Interdisciplinary Center for Ear Reconstruction, which is part of a big umbrella. And basically, I've joined forces with our ENT department, but many other divisions, such as maternal fetal medicine and developmental psychology, pediatrics, and audiology, and many more, to really start looking at patients living with microtia as very holistically as patients that need 360-degree care, because I've started noticing, due to our very high volume central fluidates, very has a very highly concentrated Hispanic population, which is known to have a higher rate of microtia incidence. And so because we had such high volumes, we started noticing trends. And for example, we started noticing trends with developmental differences or with autism spectrum disorders, etc. And we can only see these trends because we've established a center. People come from all over the state of Florida and the Southeast US and even beyond. And just to give you an idea, like, people usually see very few microtias in their entire career as plastic surgeons.
yeah.
We've seen about 140 since we started the center 2 years ago.
Wow.
And that gives you the idea of the high volume we have. So because of that, we've started noticing these trends, and we started noticing a few things also, that patients with microtia are always diagnosed at birth. And you can imagine also the shock wave that this has on the parents who are expecting their beautiful child, and he still, of course, is born as a
Yeah.
wonderful, beautiful child, but there is something different, and that can be scary, because anything that is different can be scary to
Yeah.
human beings, right? And we started realizing that, and I asked that during my consultation with parents all the time, would you have liked to know earlier? And I remember only one family who said no, and then every single other family said absolutely yes. And I asked why. And they were saying that it would have prepared them and it would have made them feel like they were not missing crucial milestones for their child, so that it would have made them feel better, like they were better parents.
Okay, that's interesting.
And I completely agree, right? Because you don't know what you don't know. So when parents come to our interdisciplinary clinic, we explain to them, we're gonna see you. We call it the ear hub. You're gonna see everyone today. We do the work for you. You don't need to know who. Oh my God, am I gonna miss a physician that I don't even know my kid needs to see, right? We bring all the physicians for you that you need to see and that your child needs to see at the same time, so that you can rest easy that your kid is taken care of 360 degrees for everything that your child needs.
It's incredible, isn't it? How times have changed, and the more information that we get, the more that we can do with that. And you just highlighted something really important. The one question that you ask parents is, would you have preferred to have known sooner, in advance? And it's something I've actually never thought about, because it's exactly as you say, Angelo. When a mum gives birth to a beautiful baby, I mean, giving birth is one thing. Having your gorgeous child with microtia, without microtia, they're still beautiful. But it's another layer, isn't it? That, then the mother's faced with questions around that. Did I do something? Could I have done something better? And perhaps if she had known this information beforehand, she could have dealt with that. I have a question for you regarding that. Does microtia show up in scans?
I love that you asked that question. We actually just started a protocol that we want to diffuse nationwide and actually worldwide, and we're about to publish, in which we're showing that yes, microtia actually is visible on ultrasound. The problem is that ultrasonographers don't focus on the ear when they do the scan. So it gets missed all the time, but it could actually be picked 100% of the time, because it's very easy to pick. We're actually publishing. We just had our first baby who was diagnosed prenatally, and I was able to do a prenatal diagnosis and counseling with a mother who just delivered her beautiful baby that I'm about to meet, I think, this week.
Oh,
Yeah, with a grade 3 microtia on one side and grade 2 on the other side. And it's amazing because we were able to counsel her and reassure her that her child is going to be just equally beautiful, equally successful, and especially because we will have prepared her on what not to miss, what milestones not to miss, so that her child will have a perfectly normal life.
that's really interesting, because I'm wondering how that could be rolled out, even globally, the test when people are doing these scans, so that these small things don't get missed, because they probably in these scans focus on arms, legs, but they're missing, and the ears are very small anyway as a baby. So that's probably why they're missing them.
But think about, I call it the psychological shockwave that it has on parents, and how important that is to prevent that. But also think about the milestones that you don't miss. So there is a model that we use all the time. It's called the 136 model.
136.
The 136 model. It's a known ENT, so ear, nose, and throat, otolaryngology model. Which means for microtia, you want patients to be diagnosed by 1 month of age. You want to see them by 3 months of age. And you want to make sure you augment their hearing by 6 months of age. So you basically put hearing aids.
Okay.
And the reason is that's part of the brain needs to also be to help develop by having access to sound and therefore being functional. And you would not believe how many times kids are born, and even the pediatricians and the neonatologists, it's something somewhat rare. They don't even know what is going on, and they may say, oh, okay, you know what? They have hearing on the other side, they're going to be fine. So just, whenever you can, just go. And actually, timing is of the essence here. So we actually are trying to turn our 136 model to a minus 136 model.
What's
so that
the
we
difference?
Can well, instead of 136, diagnosing a month 1, we want to diagnose a month -1, which means prenatally. If we can push that throughout the country and throughout the world in picking up ear differences before birth, then what we can do is actually making sure that patients reach us much earlier, and we don't miss the incredibly important milestones such as hearing augmentation at the right time that allows the brain to develop normally, and also language to develop normally. Think about how binaural augmentation or binaural hearing, which means hearing on both sides, is important for localization of sound, for safety, right? If you walk down the street, you need to be hearing if a bus is coming one side, right? And parents often don't know.
I don't notice it when I'm walking down the road. My darling other half is always like, Sasha.
Yes, you need to be aware of your surroundings, right?
Yeah.
So incredibly important. So we think that all of this and the establishment of our center has really made so many strides in trying to make these tiny little adjustments to what the center of care is, that hopefully my dream is we make this protocol and this just really standard of care worldwide, so that we can make sure that kids really are given the best chance to have an absolutely normal life.
Yeah, and Angela, it's really interesting speaking with you about this, because the conversations that I've had around surgery and the hearing side of, all relating to Microtia it's just that options are limited. A lot of times parents, they have the, appointment with the ENT, and exactly as you said, that sometimes they can hear on one side, don't worry about it, the child will be fine. And, implementing these steps is really crucial to the child's development and learning and adapting as well, especially and this is one of the things I wanted to ask you a question about, is in terms of the hearing aspect, because there's so many questions floating around, and I think parents who have children newly diagnosed with Microtia, there's a lot of these questions, and one is, like you just said, to implement the hearing aid, bone anchored hearing aid or other devices early versus waiting until they're a bit older. I know the answer already, but could you kind of explain why that's important?
Yes, so hearing augmentation, as we were saying, is critical for development and for language development, because we cannot really develop language appropriately without hearing properly. So, and unfortunately, people think, oh, one ear is going to be fine. But think about if that was your eyesight, another one of the senses.
Yeah.
Would seeing with one eye be totally fine? Would you tell a parent, oh, he has another eye?
No.
Fine. You wouldn't do that, right? Because binocular vision is important for depth perception. Now, think about depth not from a visual perspective, but from a sound perspective. And the world all of a sudden makes sense, right? You
Yeah.
need to hear with both ears, and that's why nature gave us two, right? For geolocalization, perception, depth of sound,
Yeah.
if I may say that. And it's important because all of that is necessary to develop those parts of the cortex of the brain that will also allow you to just develop normally. So hearing augmentation as early as possible, it's critical. And I cannot stress that enough. And that is why we think that managing Microtia tightly with ENT, with audiology, with our speech and language pathologists, and we're going to talk about speech also, which is critically important as well, is critical, and not just seeing it in a regular craniofacial clinic. Because what I was noticing in training, etc., that even though there is a big level of depth in craniofacial clinics, when it comes to Microtia, it's almost like we have tunnel vision. I see an ear that is missing, I need to fix it. And that's really not it. The problem is not just the external ear. The plastic surgeon needs to really have a very deep understanding of the hearing augmentation part of it, and really work closely with the ENT, because like you were saying, the hearing aid, there's different options, right? You want to start with a soft band BAHA, which means the one that you just put on with a little rubber band around your head. And that's important because it bridges you before, surgical age. And then once you have surgery with your plastic surgeon, who needs to go first, then you can do the bone anchored hearing aid that will allow you to have better compliance, because patients cannot take it off, but also it gives you incredible sound. And a lot of the time, while we're talking about hearing, one of the questions that parents ask immediately is like, oh, can we make the ear canal?
Yeah.
And the truth is, we have to do a CT scan on age 5 to really see if the anatomy of the ossicular components inside the ear is appropriate to do that sort of operation. We get a score, and we understand if they're good candidates or not. But the truth is that operation, even though it seems sexy because you can hear through the normal ear canal, etc., the truth is that even otologists who do it all the time don't really love that operation, because there's a lot of problems. Imagine a bone being a solid bone instead of being a canal. And imagine having to drill into that bone. What happens is that new canal that you created will tend to stenose again, to close again. It can actually have buildup, which is called cholesteatoma, and that can give bad problems. And also the sound that you get is just not quite amazing. So I always tell parents, always listen to what my ENT partner says. He knows best. But my understanding is that if you put a bone-anchored hearing aid, it's like having Dolby Surround. The quality of the sound that you get is much, much improved and much better. So that is usually what we tell our patients. But of course, depending on their anatomy, we can do whatever they prefer.
My understanding is, and I think you've just highlighted this, is that if you do have the anatomy in place, like you said, it seems sexy to get the whole, put into the ear. But the majority of the time, not even children. I know an adult, we've had him on the podcast, actually, Paul. He had the canal, he had it, the hole made, and it closed up even as an adult. So it's not even if you're a child, because I know that obviously children, they're still growing. So I would understand that from an anatomy perspective, but then it still transpires that it even closes up when you're an adult.
Yeah,
So,
and there is a reason for it. Anatomy tends to, if you drill a hole in bone, the bone is stimulated to grow. So it will want to close right back up. Just like when you break your arm, right? And you put a cast around it, your bone just, your body deposits, new osteoblasts, which will deposit bone matrix, and it will create a callus, and that will solidify into bone. So it would be silly to expect something different from a different part of the body, right? But also the lining inside is made with a skin graft, which is a piece of skin that you take from somewhere else in the body. And the problem with skin grafts is in biology, in human biology, is that they tend to contract. So with time, a skin graft wants to shrink, because that's how we tend to heal. We want to close things up by contracting. And what that happens is sometimes it stenoses the canal again, so it closes it up again. That is why I always tell parents, I know it sounds sexy, it seems cool to see that you have, but you can create it with the reconstruction of all ear canal, and you might give your kid much better sound access through one of these very modern devices. I even tell them they look kind of cool. You look like a robot, like from like 2250 something. Instead of having something that is not really functional, you actually have really, really good sound.
And I'm sure exactly the clarity of the sound is much better with a bone anchored hearing aid or a bone bridge versus if you have the hole done and do it that way.
Yeah, absolutely. Absolutely.
Okay, Angelo, let's talk about speech.
Yes, that is one of my favorite topics. So one thing that people often don't know is that in some instances, speech can be affected. And it can be affected because of the hearing augmentation was not done appropriately and at the right age, and milestones were missed. That's why we were saying it's super important not to miss those milestones, right? The 136 we're talking about, hopefully soon to become the -136.
-136.
You got it. But it's also an anatomical reason. An anatomical reason is because in craniofacial surgery, we call clefts, just like cleft lip and cleft palate, etc. We call them Tessier cleft because
You call it, I didn't catch the first word.
Tessier
How
is
do
the
you
name
spell
of
that?
Tessier.
Tessier cleft.
Tessier cleft, because Tessier was the father, was a French surgeon who was basically considered one of the fathers of craniofacial surgery. And he basically described the different types of clefts that human beings can be born with. For example, we have the cleft lip and palate. We have different type of clefts, and one is called the Tessier 7 cleft, which basically goes like this. And think about Microtia as the most benign, like the mildest form of a Tessier 7 cleft, which means that the embryological difference that happened during embryonic stage affected tissue in this area.
Yeah, here for me.
Right. Correct. So you
Is
can
that
have
why my
facial
lip
nerve.
goes up when I speak? Probably.
Well, it's because you can have facial palsy on that side because the facial nerve is often in the wrong position and can be paralyzed on that side, on the microtia side, because of the TCS7 cleft. Now,
That
the
explains why that explains why I got called Elvis at school.
oh, how did they call you?
Elvis. Do you remember Elvis Presley and his lip used to go up? Well, that's what I got
Yes.
called at school. But anyway, sorry to interrupt with that.
Oh, no, absolutely. I'm sorry they did that to you.
That's okay.
So what happens is that if you think about the soft palate,
Yeah.
okay, so it's the roof of your mouth in the back, right? The roof of your mouth, which is the palate, is bony, so it's made of bone in the front where your teeth
Hmm.
are, and it's made of soft tissue and musculature in the back.
Yeah.
And think about this is the back of your throat, and this is the soft palate. Think about the soft palate as something that goes back and up and closes the back of your throat as a valve. And that prevents when you speak, the air that comes out of your lungs and your windpipes and they come out of your mouth, it prevents by closing really well from it going in your nose and sounding like this.
Oh,
Okay?
wow. Okay.
That's called hypernasal speech. Now, in a TCS7 cleft, we've seen, and actually some of the pioneers of plastic surgery of Microtia have noticed that. So kudos, Dr. Ryanish, is a legend in the field. And he realized that these patients were actually having palatal dysfunction, which means the palate wasn't really moving as much. And sometimes you could have nasal air escape, which means that air that goes into the nose and makes you sound like I did before. So one thing that we always routinely also performed is a speech evaluation in our clinic because it allows us to find, and we find it, more commonly than you think, some velopharyngeal insufficiency, which is VPI, which is what we call when that soft palate doesn't close against the throat really well, okay, against the pharynx. And that can cause speech problems. So the fact that we know this, we
Yeah.
can recognize it very quickly and then potentially treat it if necessary, it's important because it allows, again, to remove that stigma of diversity in that patient.
But how would you treat that specifically?
We would treat it just like you would treat a cleft palate patient. So you can lengthen the soft palate with different techniques, with different surgical techniques that would be probably too complex to explain right here, but you can make some zigzag cuts in the palate and make it longer so that you can actually achieve better closure. That is one of them.
Wow, I'm really fascinated. I've learned so much already. It's like an anatomy lesson in Microtia. It's brilliant. I'm sure the parents and the listeners and everyone will really appreciate it. So my takeaway so far, Angelo, is that the hearing aspect is really critical. And that should be implemented, let's say -136. Hopefully it gets to that stage, but that should be implemented as quickly as possible so that the child has got the best possibility of learning and adjusting, and the brain can have the opportunity to filter out the white noise. So I get this question so much, and I'm sure you do as well. We understand that the hearing aspect is critical, and what about the reconstructive aspect? How does that work? Do you find that a lot of people come to you and they're 1000% set on having reconstructive surgery for their child if they're a parent of a child with microtia, or do you find that some of them decide to wait until their child's a bit older to make that decision themselves? And this is all to do with the reconstructive surgery aspect. What's your experience with all of those things?
It's really mixed. You will see parents who will come with a neonate and say, can you reconstruct it right now? And
Wow.
clearly that is not possible, right? We want to wait for the ear to be at least as close as possible to a fully grown ear. We know usually historically in papers and in books, we used to read that ears are about 90% grown by age 7. We actually did a study when I was in fellowship. I wanted to see, I was in a very, very major high volume hospital for my fellowship training where I did a lot of Microtias. It was Cincinnati Children's Hospital. And we actually looked at CT scans from patients who, like about 100, if I remember correctly, patients who had undergone a CT scan every year of the head. So we could actually look at the growth chart of ears basically throughout the entire pediatric life. And what we were seeing, actually ears keep growing until 11 in girls and 12 in boys. So theoretically, if you want to do reconstruction once the ear is fully grown, you should wait until 12 in boys and 11 in girls. However, we don't really do that anymore, and especially depending on the technique that you want to use. And if you are somebody who wants, for example, a Medpor ear, then you can start very early and you just make the ear much larger and the patient will grow into that with life. But if you want to use your own cartilage, we have to usually wait until the rib circumference is at least 60 centimeters or the kid is about 10 years of age. And that allows you to get to an ear that is similar to the contralateral in adult life and adult age. But that actually is a good segue to something that I'm very passionate about, because recently I've been doing a lot of allogeneic cartilage reconstruction, which means we use cadaver ribs in patients that really do not want us to take their own ribs and also do not want to wait until their kid is 12 because they're afraid of bullying. So we can actually offer microtia repair with cartilage at a much earlier age. So I start as early as 5, 6, and I can do that and shorten the operative time also by a lot, because I don't have to go into the chest and get that cartilage for those patients who want this technique. And then I can carve it on the back table at 6 o'clock in the morning before the patient even gets into the hospital. Then the patient gets into the hospital like at 9. We get him into the OR. By 1:30, we're done. Wow. And we have a 4-hour surgery instead of a 10-hour surgery. But not everything is perfect, right? So cadaver rib has a slightly higher tendency, we're seeing, to resorb a little more than regular.
But what is that rib that you mentioned? I didn't quite catch the word.
Allogeneic means from somebody else. So it's cadaver rib.
A donor, essentially.
Correct. So there are tissue banks that we can buy them from, and we get the product, and you just open the bag, and it's all sterile, it's all frozen, so there is no really any rejection to it, because there is no cells that the body can reject to. But one of the big concerns from the scientific community has been resorption versus your own cartilage. And I've been looking very closely at that, and I'm noticing that there is a little extra resorption. So far, it's not that much that makes me not want to use it, but we're still very closely analyzing data to see how this goes. It may be something that it completely revolutionizes how we do things in a few years, or something that we completely abandon if we see that resorption years and years down the road is much worse than what autologous cartilage, which is the patient's own cartilage, does, because that also resorbs. So we have to really be careful and very honest and have a very frank conversation with our patients. Okay, these are the pros, right? We're not going to get into the chest. It's safer, it's faster, shorter OR time, etc. But there's also cons that you need to be aware of, and there are also unknowns that we don't know, because we're gathering data in a very, very new technique right now.
And so when you say the cons are that did you say it reabsorbs?
Yeah.
So what do you mean by that? So what would be the worst case scenario if that did happen in this instance?
Well, that the whole construct would disappear and it will really melt away, and then you would have to reconstruct again, finding a different method. And that is why I like not to use that TPF fascia that we were talking about, because should something like that happen, you still have a way to do the TPF with an implant, for example. So it's important for me when we evaluate patients to really assess their goals, their preference. Some ethnicities, for example, really do not want their kids to undergo a surgery in which they take part of their own, ribs. And the parents are adorable and they come and say, "Can you take mine? I want to donate mine."
Oh,
And I think it's like the most heartwarming thing, and
yeah,
heartbreaking thing at the same time,
yeah,
And so we can do that with a cadaver rib. However, there is always, the chance, and we always have to be very clear, very honest, and have this very, educated conversation
yeah.
about what we know and what we don't know yet. And the fact that we're collecting all this data, we're publishing it, and little by little, hopefully a decade from now, we'll know. And we're going to continue to do this, or we're going to say, forget about it. We're going to go back to, the drawing board.
But you can see there's definitely it's definitely changing now in terms of options that are available, because it's not just rib cartilage or putting on a prosthetic here. We've got Medpor, and we've also got the other option that you talked about, using a donor's ribs. And it just makes me really curious, in the future, what else will be available? Like, because it's an extensive surgery, it's invasive, it takes a lot of time. I wonder, given more time in a decade, if you could predict what would be best case scenario that we would be looking at in terms of the treatments available?
I think the best scenario, probably not in a decade, but more than that, would be gene therapy in utero. So that if you could potentially diagnose through a DNA test, which is probably highly unlikely, but if you saw it, for example, in a scan early on, you could inject very safe either microRNA or a virus carrying a gene that would infect the cells and fix that genetic issue, then you could have a baby being fixed in utero and being born without microtia.
Yeah.
So that
And
would be ideal.
well, there's hope. There is
Yeah.
hope. Angelo, one of the things I wanted to say, and this is not just to you, but this is to everyone listening as well, is that this podcast is not to promote surgery. It's to give the listeners and the viewers options available to them, for them to help them on their Microtia journey, and, to make those decisions, because I don't feel like it's an easy decision to make. Some decide to let their children wait until they're a bit older. Others decide to intervene on the child's behalf and do the reconstructive surgery. I have a question for you.
Mhm.
If you had a child who did have microtia, what would you do?
I love that question because I talk about it with my patients all the time. There is this stigma that we want our children to be perfect. And I tell them your child is already perfect.
Yeah.
It's just different. So we need to embrace that difference and just give them the tools, first of all, to feel confident in their own body, just like you would for somebody who was maybe different in other ways, maybe slightly overweight or whatever. You would not promote body dysmorphic disorder, and you don't have to do that with your child either. So what you want to do is be very delicate and understand that they're in a very fragile, psychologically fragile state of mind during those development years, because we know that's how we are as human beings. Our mind is forming. We're still very sensitive about anything people tell us and point out. And kids, people say kids are cruel. Kids are not cruel. Kids are just honest, and they
Yeah.
tell you if they notice a difference, they're just gonna tell you, like, what's up with your ear. And the most important thing as parents is, I think, to coach love. I always tell them, love your kid, and really coach them on how to answer those questions and say, oh, because this is just how I was born. Isn't that cute? This is my Nemo ear. And turn the difference into something unique in uniqueness. And I really like that. And I always tell them, when I tell them all the options of all the surgeries we can do, the first one is not do anything, because your kid is perfect. And if they don't want anything, that's totally fine. If you want to normalize it, that's totally fine. I don't want you to feel guilty for wanting surgery for your child, because there is also a lot of psychological reasons why you may want to actually fit in. I've had a parent once telling me, thank you so much for what you're doing. My son always thought that he was the only person with microtia until he went to college. And think about the sense of loss you must have if you feel you're the only human being on earth with a condition. And that
Yeah.
is why we do yearly conferences, picnics, etc., to have all these kids meet and see that not only they're not alone, they're perfect, and they can all make friends, and they can all have people who are just their group, you know? So I think non-surgical option is an equally good option as long as the patient is educated on the fact that and is allowed to cope. And that's why we also have developmental psychology in our team, with the fact that they're just different and they're just equally beautiful. But the thing that we do not take lightly is hearing augmentation. That is a non-negotiable.
Yeah.
Even though I'm the surgeon, I'm the one telling them if there's one thing that you have to remember out of today's interdisciplinary, 10 visits you're getting today. One is the non-negotiable is hearing. Okay, everything else we can delay, we can do later. We
Yeah.
can move around to make you happy, but that is a non-negotiable.
And the beauty of all of that is time, because as long as you prioritize the hearing aspect, you can always make a decision if you decide to have reconstructive surgery later down the line, you're not
Yeah,
missing out on anything, but the hearing part is really crucial. And I think that's really something that hopefully parents will feel more at ease about, is the fact that they sometimes feel really forced into making a decision really quick when it relating to the aesthetics, but they don't need to. And like you said, it's actually the 11 or 12 you do have. If you decide to do nothing when your child is born, you could sit on that decision for 12 years. And actually you might think as a parent, I want my child to have surgery for this, but then you might wait. And I know a few people this has happened where the child is totally fine and doesn't even want to consider having surgery. Then they get to school and they actually speak to their parents and say, I really feel like I want to have reconstructive surgery. So sometimes time is a good thing.
yeah, and different parents and different children are different, and
Yeah.
you'll see some of the girls, pretty early they start looking at the mirror, at themselves in the mirror and say, can you fix this, mom? Can we get this fixed?
Yeah.
I want to look like, I want this to look like the other one. And that's totally okay. And, these surgeries require a lot of upkeep afterwards for the first few weeks, with cleaning and make sure the patients are compliant, not sleeping on the reconstructed ear, and all these things. So you really need to have an engaged parent and an engaged kid. They will let you do things, and those are the ones who do the best.
Yeah. Angelo, if you could speak to a parent of a child with microtia and give them some words of reassurance, perhaps they have just recently had their baby that's diagnosed with microtia and they're feeling a bit lost, and they're probably, because this is quite a common thing as well, most parents blame themselves. Is it something I did? Is it something I didn't do? What do I do? What do I not do? If you could, in one paragraph, give some advice to those people listening, what would it be?
Yes. So I tell them, first of all, it's not your fault. There is a genetic component to it, but there are usually very likely some genetics and epigenetics, which in fact, you can have twin brothers. They're homozygous, which means identical twins, one being born with microtia and one without, which means the DNA that they had at the beginning was identical, and then down the line, there was some mutation on the lack of formation of a vessel that caused all of that. So first and foremost, I reassure them and I make them, breathe easy, that it's not something they did. And then the fact that they're good parents because they're here talking to me today, meaning they took action in making sure that their child has all the care that the child needs, and they have nothing to reprimand themselves
Oh,
for. You know?
yeah.
Yeah, that's usually how we start a conversation, and then that we're here to guide them through a journey. And the journey is gonna basically be like that we would have for our children. I always tell them, I don't have children, these are my children. This is
Oh,
why I want to be here on this earth. I want to take care of these children, and they become my kids. We share a kid basically for
oh,
the next 18 years, and that's totally okay. So they all have my email, they all have my number, they have multiple ways to reach out to me. And that usually puts their mind at ease. And they know that they will email me at 11 p.m. And if I see it, they know that they will get an answer back from their surgeon. And it's honestly, it makes my day. Even if I'm on vacation, I get an email. They say like, look how good the ear looks, or look, we've been
oh.
doing this. Am I doing it right? And even if they get a 3-word response like, yep, and a thumbs up, you're doing great. But it reassures parents that they have access to their surgeon. I always tell them, I find it very daunting that you would perform surgery on a child and then not being able to reach the surgeon, right?
Yeah.
So I don't take it lightly that on the table I have somebody else's child. So I always tell them, your kid is my kid. I'm not going to do on him something I wouldn't do on my child. Am I perfect? By no means. No surgeon nor human is perfect.
Yeah.
And this is a very challenging operation, but I will never do on your child something I wouldn't do on mine.
That's beautiful.
Yeah, we try.
Angelo, if the listeners would like to reach out to you, what would be the best way?
I think email would be probably the best. It's angelo.letobarone@nemours.org. And they can also reach out on my Instagram. I have an Instagram account, and then we can direct them to our website to get an appointment, or our coordinator call them and schedule an appointment for them if they want to.
Okay, I'll put all of that in the show notes below. And Angelo, thank you so much, because you've taken something which is quite a heavy subject, isn't it? And it's for some reason you've brought lightness to the subject, but also education. You've given us so much information that I know some people, including myself, by the way, have never heard before. And the anatomy side of things and all of the different options that are coming up. And more importantly, it's nice to speak to someone who really cares. You clearly care about what you do, and you're not here to promote surgery in its just surgery. You're here to help and to guide and to give options. And the one thing you did say, which I love, is the first option is do nothing. So I don't think people should ever feel pressure to do surgery, but it is an option. And you've kindly taken your time today, which I really appreciate, to go through what those options look like in detail, so that parents can be reassured, because it's like a free consultation.
Yes, literally, like many of the things we said today is what I tell in what I say in my consultations. But thank you so much for having me. This has been a true delight, and I hope it was educational and useful for people.
Honestly, so useful, because I get so many questions from parents. What about this? What about that? And I don't have the answers. I'm not experiencing this, but you are. So that's one of the reasons I really wanted to get you on the podcast, is because there's so many questions around this. So I really hope that people listening, that this helps them. So thank you so much.
Thank you. It was a pleasure meeting you. Thank you.